Welcome to Rumor versus Truth, your trusted source for facts, where we dissect the evidence behind risky rumors and reveal clinical truths. Today, we'll discuss the pain points around opioids.
Now, before we start talking about claims today, Don, I've got a fun fact that will make your day. Rumor versus Truth has now reached over 50,000 downloads.
Wow. And I'm giving that claim a verdict of true, no conditions. And thank you to our listeners for being our dedicated audience, tuning in to learn more as we untangle risky rumors from clinical truths.
And I'm just glad folks don't think our puns are as painful as we thought. And with that, I'm Steve the pharmacist.
And I'm Don the pharmacist. And speaking of painful puns, we're going to talk about opioid claims in this episode to see which ones are true versus which ones need a rescue dose of evidence.
Right. And these rumors don't just cause confusion, right? They can affect pain care, overdose response, and how we treat patients with opioid use disorder.
And this feels especially important right now. The opioid conversation has changed a lot for the past few years. Clinicians are trying to balance appropriate pain treatment with safety concerns. New non-opioid options are entering the market, and old assumptions about opioids are being challenged by newer evidence.
So if you learned your opioid pearls years ago and haven't revisited them recently, this episode might surprise you.
And should we give the audience our lineup, Steve?
Well, hold on to your white coat, Don. We're going to talk about why dependence risk may start earlier than many clinicians assume, whether the new drug Suzetrigine is actually the opioid alternative it's marketed as, why antihistamines frequently disappoint for opioid-induced itching, and why opioid use disorder does not automatically rule out opioid treatment for pain.
That's a lot of clinical territory to cover, Steve. We need to titrate the puns, monitor for evidence gaps, and avoid breakthrough nonsense.
And let's keep the nonsense to a minimum by taking a moment to remind our listeners that this podcast offers continuing education credit for pharmacists, pharmacy technicians, prescribers, and nurses.
Just log into your pharmacist letter, pharmacy technician's letter, or prescriber insights account and look for the title of this podcast in the list of available CE courses.
And for the purposes of disclosures, none of the speakers today have anything to disclose.
Steve, opioids are, one of the topics where two things can be true at once. They could be essential for managing pain, but they can carry serious risks if we get casual with the details.
Right. The problem is that the casual details become clinic hallway wisdom. Like short courses are always safe, higher naloxone is automatically better, and even conversion tables are exact. Coding works for cough, like the list goes on. And it sounds tidy, but the evidence is messier.
All right. And today's claims cover both sides, avoiding unnecessary opioid harm, but also making sure patients who need pain treatment, especially patients with opioid use disorder, aren't dismissed or undertreated.
Yeah, so the theme today is not opioids bad or opioids good. It's opioids require nuance, which is the least catchy slogan ever, but clinically very useful.
Yep. Let's get into the evidence carefully, because this is one place where shortcuts can cause real problems.
Right. Let's start with a claim that challenges something a lot of clinicians have probably thought at some point. It's only a few days of opioids. What harm can that do? So the claim is that dependence risk can increase soon after initiating opioids.
I'm glad we're looking at this first. Before we go any further, we should clarify something. So physical dependence occurs with repeated use, causing the neurons in the brain to adapt so they can only function normally when a patient is taking the drug. So taking away the drug can cause several reactions or withdrawal symptoms.
And let's not confuse that with addiction or opioid use disorder, which is a chronic disease where patients develop uncontrollable drug-seeking behavior despite negative consequences, and it involves long-lasting changes in the brain.
Yeah. So with dependence, what's the time frame? And do we have studies on this?
Yeah, we have some evidence. An important observational study back from 2017 looked at opioid-naive adults, so folks that had not taken opioids yet, and found that the probability of long-term opioid use increased with each additional day of meds supplied. And the curve started changing early, with notable increases after about day 5, and again after longer initial supplies.
Okay, so this makes sense. The longer you're on it, the more the brain will be adapted to it, and increasing the risk of dependence. But that 5 days actually might surprise some, though.
Yeah, and now a more recent 2023 study looked at more outcomes, things like risk of opioid misuse, poisoning, or dependence. And this study was big, looking at almost 1 million patients who received opioids in Spain between 2012 and 2018. And they found the risk increased for opioid prescriptions written for a 4-day supply or
Wow.
longer.
So, clinically, this supports thoughtful initial prescribing. Use opioids when appropriate, but don't treat the first prescription as harmless just because it is short. Time isn't exactly on our side.
Exactly. And risk still appears to exist with short courses. So when it comes to this claim that dependence risk can increase soon after initiating opioids, the verdict is true.
So the practical takeaway here is, don't assume a short course is automatically a low risk course. Dependent risk can begin increasing sooner than many clinicians realize. Ensure opioids are prescribed for the lowest effective dose of opioids for the shortest duration needed.
And that's why opioid stewardship isn't just about avoiding long term use. It's about making thoughtful decisions from the very first prescription. An important initial strategy to limit opioid needs is to optimize non opioid meds like acetaminophen or ibuprofen first, while also using non drug strategies, things like physical therapy.
Right. And don't walk away thinking that 4 to 5 days is a hard and fast rule. We know risks can vary case by case and be weighted against benefits.
Right. As an example, while 3 to 5 days of opioids may be appropriate for most cases of postoperative pain, some patients may need more than 7 days if they've had severe trauma or multiple injuries, things like that.
So see our opioid stewardship checklist to help you limit risks when you write, verify, or dispense prescriptions. Okay, so next up is a newer drug that has gotten a lot of attention because everyone wants better pain relief without that opioid baggage. My claim is Suzetrigine is safer than opioids.
Suzetrigine, brand name Journavx. I hope I'm
Good
saying that
job.
right, Don.
I think you are.
And that's definitely made a splash recently. There's been plenty of interest in it since we've seen, or rather, we haven't seen a new pain med class like this approved for really over 2 decades.
All right. And before we start, let's be clear about something. Safer depends on what risk you're talking about. Regarding addiction potential, it's not an opioid or controlled substance. Instead, Zedrine is a sodium channel blocker that targets pain signals in the peripheral nervous system.
Essentially, meaning it doesn't do much in the brain itself, which is good because that's part of the issue with how opioids cause dependence and addiction by affecting the brain's reward centers.
Right. Plus, it avoids other opioid side effects, such as respiratory depression.
So I could see it being safer in that respect, right? But safety is only part of the equation. How well does it actually treat pain, Don?
Right. Yeah. So we randomized controlled trials in adults that showed its use for moderate to severe acute pain after certain surgeries, mostly abdominoplasties or tummy tucks or bunion removals. And they found that suzetrigine reduced pain more than placebo. And pain reduction was similar when compared to patients taking hydrocodone with acetaminophen, 325 milligram strength.
So it's better than placebo, but hydrocodone and acetaminophen, it seems like a weak opioid choice for most cases involving post-op pain, at least that I've seen. Um, Even if the study's looking at bunionectomies, right?
Right. And this is where the condition part walks in, wearing sensible shoes.
Always with sensible shoes.
You know, typically see that low hydrocodone acetaminophen dosage used in other surgeries, especially not for major and intensive surgeries. And these studies only looked at using it up for 2 weeks, which is a reasonably short duration. So this is hard to apply to a lot of cases, and we don't have a lot of data confidently to say suzetrigine will really step up to the plate there.
Yeah, time will tell with more evidence. And suzetrigine has drug interaction issues, specifically CYP3A pathways, right? So it may not be the safest option depending on patients' other meds.
Plus, it's costly. It's about $15 a pill, which can represent insurance barriers. Even a medication with advantages on paper isn't particularly helpful if insurance barriers or waiting for authorizations prevents patients from actually receiving it. So going back to that claim, Suzetrigine is safer than opioids, and the verdict is true with conditions.
So it's safer than opioids in important ways? Yes, especially regarding addictive potential and some opioid type adverse effects. But don't turn non-opioid here into a synonym for risk-free, right? Suzetrigine comes with a different set of trade-offs than opioids, like questions around pain control, duration, interactions, and obviously cost.
Yeah, so I like to think of Suzetrigine as a promising non-opioid option for short-term acute pain, not a universal replacement for every opioid in every pain scenario.
Yeah, and don't compare it to opioids only by asking, does it work? Also ask for whom, for how long, with what interactions, and compare with what alternatives. I'm sure some clinicians listening are asking, well, should then we be excited about this new med?
Oh, we can celebrate all we want, just don't let excitement replace critical thinking.
Which might be the unofficial theme of this entire podcast, to be honest.
You know what else is exciting? We also have a list of other non-opioid meds that might help your patients, and our analgesics for acute pain in adults resource. It can help you compare options, including Suzetrigine. And speaking of resources,
Yeah, we've linked directly to several related TRC resources in the show notes, including tools on opioid prescribing, opioid safety, and pain management.
if you aren't already a subscriber, don't miss out on these resources. Sign up today with listener code RVT1026 at checkout to get 10% off to help you stay ahead with trusted insights and tools.
And with that, now we're going to do more than just scratch the surface with this next claim. And it's that antihistamines are very effective for opioid induced pruritus or itching.
Yep. So I feel like I commonly see antihistamines like diphenhydramine and hydroxyzine used for opioid-induced itching or pruritus, but now I'm second-guessing the evidence.
And perhaps you should, Don. Itching can occur with certain opioids, commonly codeine and morphine is the most common. But since these meds increase histamine release, right? But this is generally not considered an allergic reaction. Think of it more of as a side effect.
But, I could see folks might think histamine equals itching and histamine equals fixed.
And histamine may play a role, but it isn't the whole story here. Opioid receptors themselves appear to contribute a little bit to the itching response, which helps explain why antihistamines often underperform. Most evidence we have for antihistamines are actually from studies involving pregnant women receiving diphenhydramine for itching from opioid epidurals, during labor and delivery. And diphenhydramine in those studies wasn't much better than placebo for preventing itching.
Right. And it's hard to extrapolate that trial data to other scenarios and populations. That situation would never apply to you and me, Steve.
Very true, Don. Plus, there might be more effective options. A handful of studies looking at IV opioid antagonists like nalbuphine and low-dose naloxone infusions for treatment of morphine epidural pruritus show that they perform better than placebo and sometimes antihistamines.
Right. So then why do you think antihistamines stick around for this?
Don, I'm wondering if it's probably the sedation. Maybe they don't directly treat the itching. Maybe some patients perceive relief because they're less aware of the itch or scratch less. It literally just makes you forget you're itching.
Right. So yeah, if you're asleep, you're not really itching, right? So it's more like it makes you forget you're itchy rather than targeting the problem. Plus, I worry that combining antihistamines can warrant opioid side effects like drowsiness or slowed breathing, uh, even down things like constipation and urinary retention.
Yeah, and that's where I worry too. If we're adding a sedating antihistamine to a sedating opioid, we may be ending up increasing drowsiness and other unwanted effects without really solving the itch problem. So when it comes to this claim that antihistamines are very effective for opioid-induced pruritus, the verdict is rumor with conditions.
Antihistamines aren't necessarily a reliable way to manage itching from opioids based on limited evidence that we have.
Right. First, avoid opioids that are prone to itching in the first place, like codeine or morphine, when possible, and use options up front or switch to ones with lower risk, such as oxycodone.
Right. If the patient has itching in the hospital, consider IV nalmefene or low-dose naloxone infusion.
Yep, see those all the time. And if the medical team or patient still wants to try an antihistamine, lean towards a less sedating option. I'm thinking options like cetirizine or loratadine to limit those sedating side effects.
Right. So the bottom line isn't that antihistamines never work. It's that data show we can't say they're very effective.
And before labeling a patient as having an opioid allergy because of this itching, make sure you're distinguishing a predictable side effect from a true allergic reaction here.
Mhm. And that's where investigating possible drug allergy or sensitivity resource can help.
Love that. Nice, Don. And now everyone's favorite segment, Fast Facts.
So this is where we jump into common bite-sized claims about opioids and give them a seal approval or debunk them quickly.
And first up, intranasal naloxone doses over 4 milligrams are more effective for opioid overdoses.
The verdict is rumor. 2024 study compared 8 milligrams versus 4 milligram intranasal naloxone, found no significant differences in survival or number of doses administered, but higher withdrawal signs and symptoms with the 8 milligrams.
So, more naloxone is not automatically better naloxone. Give repeat doses when needed, but don't assume the higher dose product improves routine outcomes.
Correct. Next claim is equianalgesic conversion tables are precise.
Verdict here is rumor with conditions. They are useful guides, but they are built on limited data, often single dose studies, which I was surprised to hear, and they do not account for patient specific factors such as organ function, genetics, tolerance, interactions, or what you're even rotating to.
So use your table and then use that brain, which inconveniently is not available as an app update.
Very true, Tom. And our last claim here is that codeine is an effective option for cough.
The verdict is evidence is mixed. Codeine has a long history of being an antitussive, anti-cough, but trials and reviews often fail to consistently show clear benefits over placebo for common acute cough. And CYP2D6 metabolism creates variability and safety concerns in certain patients.
Especially children, right? FDA and the American Academy of Pediatrics recommend against codeine cough suppressants in kids under 18, and they're contraindicated in kids under 12, since risks such as overdose, dependence, and slower breathing outweigh codeine's benefits.
So notice the pattern? A lot of opioid myths start with a simple rule and fall apart when you look at the details.
Which means we're perfectly prepared for our final claim.
Yes, we are. And this claim can cause real harm. The clinicians just treat it as an absolute. And that claim is patients with opioid use disorder, or OUD, can't be treated with opioids for pain.
I'm glad we're tackling this, Don, because we get a lot of questions about this.
Yeah, indeed we do. It's important to note here that patients with OUD still experience acute pain, surgical pain, trauma pain, cancer pain, and chronic pain.
Right. And I think this is where a lot of clinicians start feeling uncomfortable. Nobody wants to undertreat severe pain, but nobody wants to trigger relapse, worsen misuse risk, or interfere with a patient's meds for opioid use disorder, or MOUD, either. Meds like buprenorphine, methadone, naltrexone.
Exactly. And that's why simple rules, they don't work here. Quote, never use opioids is too simplistic. Quote, treat them exactly like everyone else is also too simplistic. These situations usually require thoughtful planning and coordination.
And you actually wrote an article about this recently, Don, in the August issues of Pharmacist Letter and Prescriber Insights. So what are some good tips to think about here?
Yeah. Well, for mild to moderate pain, optimize those multimodal non-opioid analgesics first. Things like acetaminophen, ketorolac, or nerve blocks if you're in the hospital.
And if non-opioids aren't enough?
Expect to add a short-acting full opioid agonist. Things like hydromorphone, fentanyl, morphine, things like that. Higher initial doses may be used to overcome receptor blockade and tolerance from those medications for opioid use disorder, or MOUDs. And also methadone and buprenorphine are usually continued as those MOUD.
And that makes it important to verify home doses directly with the patient or their treatment program, because we know prescription drug monitoring program databases with your state may not reflect current dosing of those meds.
Excellent call out, yes. And those MOUD regimens may be adjusted to do double duty as analgesia, such as splitting daily methadone doses into 3 doses per day and buprenorphine split into giving doses every 6 to 8 hours. Doing this can help utilize their short analgesic windows. Going back to that claim, which is patients with opioid use disorder cannot be treated with opioids for pain, the verdict is rumor.
So, to be clear here, patients with opioid use disorder can be treated for pain. And sometimes that includes using opioids, but it should be deliberate, coordinated, and risk aware.
Yeah. And unfortunately, this is one of those rumors that can cause real patient harm when people believe it.
So, don't use opioid use disorder as a reason to dismiss pain. Use it as a reason to plan carefully. If you work in a hospital, see if you have an addiction medicine team that you can collaborate with to design a safe plan.
Yeah, good call out, Steve. And for community pharmacists, coordinate with the patient's MOUD prescriber when possible. Use multimodal analgesia and document the goal and duration, monitor it closely, and avoid stigma in the language that you use.
All important steps. And for technicians, you can help by checking with the patient or their treatment program to see what their actual MOUD regimen is. Prescription drug monitoring programs, or those PDMPs we talked about, aren't always current, since regimens change frequently.
We got a great FAQ, which is treatment of acute pain and opioid use disorder, to give you more tips on safe approaches in these complex situations.
That is a great and popular resource. And in terms of our episode today, the bottom line truth is that opioids are not villains, heroes, or shortcuts. They are high stakes tools, and the safest tool is one used deliberately.
Of that. So today's claims were different, but they all pointed to the same lesson: beware of absolutes. In opioid care, simple answers are often the most dangerous answers.
And that's why good clinicians don't rely on assumptions. They rely on evidence, context, and careful patient-centered decision-making. Now we've got you thinking, and hopefully not itching, claim CE credit and access evidence-based resources from Pharmacist Letter, Pharmacy Technician's Letter, or Prescriber Insights.
Yeah, if you're not yet a subscriber or want to upgrade, you can save 10% with our exclusive listener code, RVT1026 at checkout. Easy link in the show notes.
And if you're already a subscriber, tap the claim credit link in the show notes or search your CE organizer for this episode.
All right, and now, mailbag time. We got an audience question from our previous laxative episode come through our rumor versus truth at trchealthcare.com email. And they asked us, is it true that polyethylene glycol needs to be separated from other meds? And if so, by how long?
Good question. And we had to sit and ponder this one.
Those puns came rolling back, which for a laxative question is either very fitting or, very unfortunate. If you're curious, just scroll your feed for the bonus mailbag and you'll find our full answer there.
And if you'd like to have your question about this opioid episode answered for our next bonus mailbag, whether it's about naloxone, itching, OUD, cough, or other rumors, send it in.
Email us at rumorversustruth@trchealthcare.com or send us fan mail right from the podcast show notes. We also use your suggestions and feedback to plan our episodes.
And join us next time, where we'll tackle unique claims about generic meds.
Yep, we'll see which claims are truly interchangeable or which ones come with very important exceptions. So thank you for joining us on Rumor versus Truth, your trusted source for facts, where we dissect the evidence behind risky rumors and reveal those clinical truths.
We'll see you next time.